with that fantastic look to the future, I get the somewhat dubious role of trying to defend the role of chemotherapy in this disease. What I've tried to do in my presentation, which I'm hoping has arrived and will in a second, is to just give you a sense of the fact that chemotherapy is one of the cornerstones of treatment. I don't think we can walk away from any options. I don't think we have the luxury of giving up any treatment options. We need to think about the cornerstones of treatment. Surgery, and you'll hear about that next, chemotherapy, radiation therapy, and of course embracing some of the new developments of the targeted therapies and immunotherapy. So these are my disclosures. And what I want to quickly just make clear is where chemotherapy may have a role in three different settings. So first of all, you'll hear the term adjuvant chemotherapy. So just for those of you who are not familiar, we talk about this in very specific scenarios, and that is, if the cancer has been completely removed by surgery, we then talk about adjuvant chemotherapy. And the aim there is to reduce the risk of the cancer coming back. So we are going for cure. You will then hear about treatment in first line. So this is largely in patients where surgery may have been performed and the cancer has relapsed, or in fact, as happens in most cases, the cancer has been diagnosed at an advanced stage and it's not possible to do a curative operation. So the aims are different. The aims are about trying to control the disease, stop it growing, stop it spreading, but also importantly, maintain or improve quality of life. And this is where the impact of any side effects is very important. And you'll hear about second plus line chemotherapy. And this, again, is for patients who may have had a lot of chemotherapy for advanced disease, and at some point the cancer has then progressed. And then we talk about a further line of treatment. And again, this is very much about trying to maintain quality of life, stop the cancer growing. And when I have discussions with my patients, especially when they've been diagnosed with advanced disease, I think that impact on quality of life is very important. And when we have the discussion, it's very much about how we can maintain quality of life. Of course, patients want to live longer. We want them to live longer. But we also want to make sure that we get the balance right. You've seen at the bottom of all of those boxes is that there's areas of research in all three of those themes. And what I'd like to do is to highlight within each of those areas some developments over the past year or so. Importantly, we all want the best treatments. And the treatments that we're having today are largely benefiting from patients who've gone before us. And participation in clinical trials does help to improve outcomes. And this relates to an individual, but also for future patients coming in future years. I'm very pleased to see that research in cholangiocarcinoma is increasing rapidly. This is a slide I showed last year. You can see in 1949 there was one paper published on cholangiocarcinoma. These are 5-year segments, and in fact the last one had 536 papers in 2011, nearly 1,000, so 918 in 2015, and in fact in the last year it's gone over 1,000. So I think we are as a community hopefully making more strides in this disease. But let me quickly update you on what's happened over the last year in adjuvant chemotherapy. So just to remind you, this is after patients have had curative surgery, and a study was just reported, in fact a couple of weeks ago, which was the French adjuvant study called Prodige 12. Within the study, patients who had undergone surgery, and this wasn't just cholangiocarcinoma, this also included patients with gallbladder cancer. But patients had to have had a completely removed tumor at the time of operation, and were then able to potentially start chemotherapy within 3 months of surgery. At that point, patients were allocated into one of two groups after giving informed consent. The standard is for surveillance only. So patients who had started to recover continued to recover without any additional chemotherapy. Or patients then received gemcitabine and oxaliplatin, or GEMOX chemotherapy, for a period of 6 months. I don't have the luxury of time to go through all the details of the study, and they have been presented once. The paper's not yet been published, but in summary, there was unfortunately no improvement from adding GEMOX chemotherapy after surgery. This has created a lot of debate and discussion amongst clinicians. We want to know, was there really no benefit? Was the benefit not seen in all patients? Were there some patients who did benefit? And I think it's important that over the next few weeks and months, we get a little bit more detail to try and understand better what this means. In fact, there are two studies that are still ongoing. One of them is a study that we've been involved in the UK called the BILCAP study. And in fact, this study completed recruitment a few years ago. It has been in follow-up. And in this study, again, it was a study comparing observation after an operation with 6 months of capecitabine and oral 5-FU chemotherapy. This study is now ready to report. We're pulling all the last bits of information together, and we will be reporting this at ASCO in June of this year. The Actica study, which is being led by Germany, but we're participating in the UK, is asking the same question, but this time looking at cisplatin and gemcitabine chemotherapy, some of which you'll be familiar with. But the important question is, what does this mean for patients now in 2017? I think the study has taught us that if we take all patients, there doesn't seem to be a benefit from adding chemotherapy with GEMOX, according to the results of the French study. And we do need to wait for the results of further studies which are coming. But we're also very mindful that the use of adjuvant chemotherapy and sometimes radiotherapy does vary widely, and it usually depends on whether the lymph glands were involved at the time of the operation and were subsequently removed, or whether the margins were clear at the time of surgery. But I think the message here is there is still a lot to be learned about the best use of treatment in the adjuvant setting, and we certainly would encourage patients to participate in our ongoing clinical trials. I don't expect you to read this, but I'm moving now on to advanced disease. This is the same site, clinicaltrials.gov, looking at many ongoing studies in first-line treatment. So this is when the cancer has been diagnosed at an advanced stage. But what I want to do is take out two studies from this list just to illustrate a couple of points. The first is about the development of new chemotherapy options. The second is how we can add on to established chemotherapy options. So in the first study, which is called the ABC08 study, which we're running in the UK, what we're doing is we're evaluating a new compound which is similar to gemcitabine. So just to orientate you, along the top, you start off with gemcitabine. It can't get into the cell by itself. It has to go through a gate or a gatekeeper we call HENT1. And once it gets into the cell, it then gets broken down into two segments. One of them is the active gemcitabine, which then attacks the cell. But you do get byproducts, and these byproducts can sometimes, and very often, cause unwanted side effects. What the new compound called acelerin does, it delivers the treatment into the cell. It doesn't need the gatekeeper. So if the cancer cells don't have the gatekeeper, the treatment still gets in. Once it's in, it doesn't get broken down by the same enzyme that gives you some of the metabolites that can cause more side effects before having its anti-tumor effect. So in theory, it may work better. It may work better at a lower dose. It may do so with less side effects, and it may overcome resistance. And in fact, in one of the very early phase 1 studies, there was a patient with cholangiocarcinoma who had progressed on gemcitabine chemotherapy, who was treated with acelerin, and in fact, they had a response to treatment. So what we're doing at the moment is to get a safety combination study of acelerin with cisplatin. That's called the phase 1b, the ABC08 study. And once we find the right dose, and so far 8 patients have been treated, we will be able to make the recommendation of the appropriate dose. And in fact, we will then roll over into a phase 3 study, which will be led by Jennifer Knox and the team in Toronto, Princess Margaret. Let me give you another example. This is where we're looking to add a treatment onto established chemotherapy. And I wanted to highlight this particular study just because of the way the study has been designed, which increases the chances of patients receiving an experimental agent. So with most studies, you've got 2 arms. And so if you look at the first 2 boxes at the bottom on the left, One group receives gemcitabine and cisplatin with a new agent called ramucirumab. In the next box is still the gemcitabine and cisplatin chemotherapy with a placebo. If we were to design this study from scratch, half of the patients would receive ramucirumab, half would receive placebo. Remember, everybody gets the standard chemotherapy. So 50% of patients would have been receiving placebo. If we take the two boxes on the right, the pink boxes, this is a different drug, a drug called merestinib, which again can be compared to a placebo. And if we did that study as a head-to-head, once again, 50% of the patients would be receiving a placebo. But by combining these two studies into a single protocol, the statisticians have been able to advise us that we can do what's called a 2-to-1 randomization. So let me walk you through this. For 6 patients randomized, 2 would receive treatment with ramucirumab, cisplatin, and gemcitabine. 2 would receive treatment with merestinib, cisplatin, and gemcitabine. And 2 patients, 1 in each of the arms, would also receive the chemotherapy, but this time with a placebo. And that means that only 1/3 of patients are receiving a placebo and 2/3 of patients are receiving a new experimental agent. So there is a way that we can move towards optimizing the number of patients who can receive access to some of the newer treatments. This study is ongoing at the moment. It's recruited about 150 out of 300 patients and is open globally, including in Asia. And then we talk about second-line chemotherapy. Again, there's a list of studies here, and I want to use one of ours just to highlight specifically the second-line treatment or the role of second-line treatment. Prior to setting this up, one of our fellows who's in the audience today did a systematic review of chemotherapy in biliary tract cancer and looked at every study in the literature, and we tried to pull out what were the messages. And in fact, one of the things we found is that there were many studies, including many patients who'd gone into the studies. Nearly over 800 patients had taken part in all the various studies, but all of the studies were rather small and were not able to tell us which was the best approach. We can also tell that patients are willing to participate in clinical trials, and we very much felt that we needed to focus on studies that had the potential to change practice. So on that background, we set up the ABC06 study, which is really asking the question, how much benefit does giving further chemotherapy bring to patients? Because one of the difficulties is with cholangiocarcinoma is that you can run into problems with blockage of the bile ducts, superadded infection, the need of a stent, a second stent, a third stent, a fourth stent, and with each of ones you can get more and more problems with infections, which can be difficult to manage. And in fact, managing those complications is probably the most important element of what I call good hepatobiliary oncology. And the question here then asks, on top of that, how much benefit does chemotherapy add? So in this study, everybody's getting this very close medical monitoring with active symptom control, as we call it, and half of the patients are also receiving chemotherapy with oxaliplatin and 5-FU. Judging by the recruitment, we will complete the study by the end of this year. We're projected to complete recruitment in November, and I'm very grateful to the 119 patients and their families who have so far participated. We're 73% recruited, and we've also looked for funding for the Trans ABC06, which will allow us to answer some of the additional questions about why patients benefit if they do, or conversely if they do not. But as you've already heard, we are in an era of precision medicine, and what we all want to do now is to think, if I have a tumor, can it be profiled? Can I get a signal from that profiling as to which treatment would be the best for me? And this paper is a very busy slide, I acknowledge this, but it really summarizes a lot of the pathways that we as clinicians are considering. And it includes a number of clinical trials, which we'll hear about over the next couple of days, FGFR fusion rearrangements, IDH mutations, the Notch signaling pathway, the Wnt signaling pathway, and all of these have got potential targetable mutations that we can target. But the question then is, does blocking the particular pathway actually lead to improved outcomes? How do cancers become resistant to those therapies? And we need to learn those lessons. And if everybody doesn't benefit, are we able to identify small groups of patients who have the most benefit, or conversely, have no benefit at all? So just to quickly wrap up, I hope I've convinced you that chemotherapy does remain one of the pillars of treatment, but we do need to do better. We need to do better both in the adjuvant setting as well as in advanced disease. Genomic technology now is much more easily available, but we need to assess the profiles. We need to do these promptly and critically. We need to understand what the new targets mean and translate this information into drug development, and that's already happening, and you'll see some of the stands outside relating to that. I'm very, very keen that we have efficient clinical trials so that we have just the number of patients that we need to answer some of these questions. And just to highlight, I think the message came through earlier, that multidisciplinarity is important in managing these complex cases. With that, I'd like to thank patients and caregivers. I'd like to thank our charity in the UK, AMMF, who have done a lot of work in supporting our work, as well as Cancer Research UK, of course the foundation here, and just signposting World Cholangiocarcinoma Day. Thank you very much.